It's a case of multinodular goiter with retrosternal extension managed by total thyroidectomy, and total thyroidectomy, it's postoperative day 2 of the patient. Patient is vitally stable. She's taking oral sips. There are no symptoms of hypocalcemia in the patient. This patient is stable, sir. Drain output is no voice changes also, sir.
No features of hypoparathyroidism. Now, Junaid, how do you approach in our setup the retrosternal goiter? What are our techniques?
So, for the retrosternal goiter, sir, first we get one CECT done, sir, to look for the the supply of the gland. Most of the time it is the plunging thyroid only, which because of negative thoracic pressure, the cervical thyroid goes down in the mediastinum, which is easy to approach using cervical incision, and it can be brought up easily during the surgery because no supply is there. But the problem comes when the supply gets to the mediastinum. So with CT which confirm, then we can go for sternotomy and we can take care of the pedicle.
Okay.
But the most of the patients which we have dealt, they can be easily managed with the cervical incision.
What did you learn in the process yesterday?
Sir, I have seen the proper anatomy, the recurrent laryngeal nerve, the external laryngeal nerve, and how you go about retrosternal and look for the short vessels and tie all the vessels completely.
See, they're both right. I wanted it to come out first. So we do CT so that we can grade this retrosternal extension. Above the innominate vein, up to innominate vein, and below that, right? Anything which is touching the innominate vein, we try to have a sternotomy set ready. So we had kept that backup. Okay. Most of the time, the blood supply is coming from the cervical region only. So the goiter, the thyroid has to arise in the thyroid fossa. So the supply is above. So we start from above only. We ligate all the vessels so that it is devascularized, and we have to deliver it out. But never use fingers to pluck it out. You may cause eversion of the vein, and then it is very difficult to manage. So we went superiorly first. We got all the pedicles ligated, and we got the 4 parathyroids, 2 here, 2 that side. And we went down to the thyrothymic ligament to look for the 5th parathyroid, which may be the seen in 5% individuals. So always preserve that fact. And as was discussed in the case before, you find out parathyroid by the color that it has, and then importantly by the change in color as you approach it. Golden yellow is the color which changes to congested one as you approach it, something that we call as parathyroid is getting angry. Secondly, the sentinel pad of fat, which is always accompanying this. Thirdly, by its location. Superior is by and large constant in location. Inferior is going places because it develops along with thymus, goes down. Inferior from the 3rd and superior from the 4th. It's just the opposite. So these are the 3 or 4 ways. Then there are other ways. As she was mentioning in parathyroid case, you should know where it lies. You should know with whom it lies. And you should also know these additional features. So fat on the gland should not be taken away. Fat belongs to the patient in this case. In TME, fat belongs to the rectum. Here the fat belongs to the patient. So if you leave the fat behind, the chances of you taking parathyroid are very, very limited. It's a very important point. The other precaution you take is you do not ligate the main trunk of inferior thyroid artery, which you saw in this case very clearly.
Capsular branches.
Just the capsular branches, because they would have given off the parathyroid supply. And Junaid was very right in that case when you talk about the intrathyroidal parathyroid. You can find it in 1 to 2% cases that there's a parathyroid in the thyroid gland within the thyroid gland. But mostly it will be outside. Why? Because it is coming from somewhere else. It has nothing to do with thyroid. It just ends up lying there. Arises from the parafollicular C cells, and it is just lying in close proximity. And what is the characteristic of the capsule which is covering the thyroid?
False capsule.
It's a false capsule.
Condensation of deep fascia around the thyroid.
I couldn't hear what you said.
Condensation of deep fascia around the thyroid gland, not retrosternal.
Condensation of
Pretracheal.
pretracheal fascia. It's like this. That's why I took it off. This is the bucket handle. Thyroid is inside it. So that's the thyroid. This is the condensation you talk about, which is attached to the part of larynx, and the inferior constrictor also comes and lies here. So when you swallow, it pulls up. But it ends here. It's not continuous. You can see that it's closed like this. So it's kind of it is encased. Parathyroids lie outside. That's why if you do capsular dissection, parathyroids won't come in your way. आपके बारे में नहीं बात हो रही है, आप मत घबराएं, है ना? पता चला आप ज़्यादा पढ़ गई इनसे, फिर मुश्किल हो जाएगा. So the aim was, when you say total thyroidectomy, I use the term remove 4 glands, preserve 4 glands, 4 nerves, and you're done. The 4 glands are 4 parathyroids, 4 nerves are 2 external laryngeals and 2
Retrosternal.
That's what we did. And retrosternal part was taken off carefully under vision dissection, not blind. Making sure that you do capsular dissection. The moment you were going in the capsule, you're putting the capsule away, parathyroid is not going to come. So if you do capsular dissection, parathyroid is safe. What would you do now? We'll keep a good, we'll observe for the, she came with orthopnea. She's the patient where we saw the Pemberton sign was positive. CT was therefore mandatory. But now we'll make her mobile. She'll take a little while. There was a space there. How much is, we normally don't put a drain, but we'll put it because there's a lot of cavity. How much is the drainage today?
Since yesterday, 100 ml has come, zero sanguinous.
Now it's looking dry.
Yes, sir.
So we'll watch it till tomorrow and we'll get it off quickly. What else will you do after 48 hours?
I will get a serum calcium done.
Right, so accordingly we'll manage. That's the protocol we follow. Any questions? Yeah?